I'm Hussein Ali, a PGY1 resident at Naples Comprehensive Health, and today I'm presenting a very interesting case of Triatrium sinistrium in an 80-year-old patient. Triatrium sinistrium is a rare congenital cardiac condition. The incidence is about 0.1 to 0.4% in all patients with congenital heart defects. It's a condition with abnormal septation within the atria, which can result in obstruction of flow of blood inside the atrium. And we have the case we are presenting is an 82-year-old female with a past medical history significant for hypertension, persistent atrial fibrillation with a history of ablation, currently on Eliquis, chronic heart failure with mildly reduced ejection fraction, obesity, pulmonary hypertension, chronic hypoxemic respiratory failure on supplemental oxygen at home, persistent asthma, and mild cognitive impairment, who came in from her PCP office for evaluation of word finding difficulty as well as lower extremity and facial edema. She had a similar episode of word finding difficulty about 6 years ago. At that time, it was considered to be due to sepsis and hypoxemia. The patient presented without any symptoms indicative of sepsis or infection at this time, and she reported good adherence to her anticoagulation therapy. On further evaluation, we did not find any focal neurological deficits. A CT scan of the head was ordered, which showed no hemorrhage, mass effect, or midline shift. Lab work was significant for an elevated proBNP compared to baseline. During the admission, we found her to have AFib with rapid ventricular response intermittently on telemonitoring, for which we work her up for with an echocardiogram, and which showed an EF of 55 to 60% with no intracardiac thrombus or patent foramen ovale. However, the echo did reveal a mildly dilated left atrium with a band-like structure, suggesting the Triatrium sinistrium. We reviewed previous CT scans of the chest from prior admissions, and which did show the septum in the atrium, confirming its presence. However, it did not reveal any interstitial or parenchymal lung disease. Cardiothoracic surgery was consulted for this patient, which recommended no invasive procedure due to the lack of severity of symptoms and her advanced age. As for her facial swelling, we did extensive workup, including for hypercortisolism, which did not yield any positive results. However, and she did not have any recent medication changes, no recent use of steroids or associated rash or mucosal involvement. The exact etiology for her facial swelling remained unknown. For her lower extremity edema, she was treated with IV Lasix, and it was attributed to venous congestion, likely due to heart failure. And for her atrial fibrillation with rapid ventricular response, it resolved spontaneously while on home doses of Corex and digoxin. The word finding difficulty was considered secondary to decline in cognition, and she was advised to undergo further neurocognitive evaluation in the outpatient setting. So, this case highlighted the incidental discovery of CTS in a patient who may have had the sequelae of the congenital defect, like the congestive heart failure, the atrial fibrillation, and the pulmonary hypertension. And patients usually with incidental finding of CTS in adulthoods are asymptomatic, but they are at risk for cardiac condition that can occur from the distorted anatomy. We need further research to develop guidelines for regular follow-ups, including imaging for patients who are asymptomatic. Thank you.